Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to Concussion Corner podcast. My name is Dr. Jessica Schwartz, your host, and I'm joined tonight with Dr. Tad Seifert. He is currently the director of Norton Healthcare's Sport Neurology program in Louisville, Kentucky. Dr. Seifert is an independent neurotrauma consultant for the NFL, serves as head of the NCAA Headache Task Force, and is chairman of the Kentucky Boxing and Wrestling Commission Medical Advisory Panel. His research interests include post-traumatic headache in athletes as well as combat sports medicine. Welcome to the podcast, Tad.
Thanks, Jessica. Great to be on.
How are you doing this evening?
I am doing great. It's a little cold here, but other than that, going strong.
Yeah, I think we're in a deep freeze throughout the whole entire country, so all good on that front. Well, I appreciate having you on tonight. I know our listeners are going to just have a wealth of information from you. We've known each other for a few years now, and we actually found each other through the American Headache Society through some of your work. And it's just been so consistent, and it's great to have a consistent voice in the neurology field. So I'd actually wonder if you could let us know about one of your new projects you've got going on over at Norton Healthcare in Louisville, Kentucky, with your concussion headache program.
Sure. We just a little under 2 months ago moved into a new site where I'm very fortunate to be able to house really all of the key aspects of a comprehensive sports neurology program under one roof. And that includes, myself as the directing physician, but I also have a nurse practitioner, Laura Yeager, that works along with me. And then we also have there on site vestibular therapy, we have cognitive rehabilitation, cognitive rehab, we have certified athletic trainers, we have a consulting neuropsychologist that's not there 24/7, but is at our ready access when we do need that, as well as visual therapists and visual therapy. And then lastly, we're able to now do on-site baseline testing, computerized neuropsychological testing, post-injury testing, and we're also doing some work with QEEG, both as a baseline and post-injury testing mechanism in that regard. So I feel really, really fortunate, having forged through a more traditional neurologic practice setup for my first 10 to 12 years of practice. Now to have this, I feel very, very fortunate.
Absolutely, and it's so nice to hear that you really have a comprehensive interdisciplinary team under one roof, especially for this concussive injury. I know that you were out in Berlin at the International Consensus Statement in 2016, October 2016, and I know, this is our first year, coming up in 2018. It's only been less than a year that we've internationally agreed that concussion is a rehabilitative injury. And, from a physical therapy standpoint, from my background, and, also as a patient perspective as well, I went through the injury myself. The rehabilitation component of this injury is so often missed. It's either underdiagnosed or misdiagnosed, or we kind of allude that our patients are malingering, or it's quote unquote all in their head, right? And we refer them to psych. But I always say, patients don't have the subjective language to express the what and how they're feeling when they have a brain injury. And that's why, we really stress the importance of a comprehensive physical examination with an exquisite subjective history from our patients. And, our providers often don't know what they're looking at, so they don't really know what they're looking for with concussion, because there's so many, misconceptions in this field from a healthcare standpoint.
Absolutely. I'm sorry, go ahead.
Yeah, no, go after it.
No, and I agree on all accounts what you just said, and I think, really looking back the last, probably 6 to 7 years, there's just been such a wealth of data and of publications that have come out on this injury, and when you really take the 30,000 foot view, at least in my own opinion, there are really two key things that continue to jump out at me. And that is that number one, the injury of concussion is not a static injury. It is very much dynamic. It is very much a rehabilitative injury. And then number two, it's an injury that is best served by a multidisciplinary approach. And I think it's those two things that continue to be stressed over and over and over in the medical literature. This is an injury that can be addressed. It can, be rehabilitated, and people can recover from this injury. And then secondly, to have the most optimal outcome from this injury, it's one that needs to be addressed from many different angles.
Absolutely. And I totally agree. And we're totally on the same library, same page, everything there. In terms of your experience, and then what will happen to, your training and so on and so forth, and your historically where you've been with this injury in your career. But what are you seeing, with folks that are coming into your clinic? One thing that I speak on and kind of push out as one of my public speaking components is this central tenet of, with, unlike cancer, brain injury and concussion, which those two words are synonymous, we have infinite ports of entry of care for an initial evaluation. So it can be sideline if it's an athlete with an athletic trainer, if someone's lucky enough to have one on the sideline. It can be an urgent care center. In fact, it can be, an OBGYN that's doing a yearly exam on their patient, and they had a slip and fall on a ski slope, and they're presenting with signs and symptoms of brain injury and concussion. What are your experiences, maybe, top 2 or 3 consistent things that you're seeing with patients that have tried to see other providers, but I don't want to say have necessarily been mismanaged, but just haven't been put on the most efficient track or pathway for their care, for their trajectory of healing? Right,
and that's a good question. And in my own practice, which anymore is about 85% sports concussion, so I come at it from that angle primarily, and about 50% of my referrals come from athletic trainers in the community and here in the region. So at least with a significant number of my patients, I'm seeing them almost literally from day one. But the other 40 to 50% of my referrals come from emergency rooms, from other primary care physicians, from neurologists, from like you said, even as obscure as an OBGYN that just gets into the history with their patient and becomes aware of a recent injury. With those referrals that come from outside the athletic training venue, probably the first or the top 1 or 2 stories that I hear is that number one, the provider that they were going to just simply didn't seem to understand the injury itself, and made that mistake of thinking that a concussion or their mild traumatic brain injury was a static injury, and what you see is what you get, and where you are is where you're going to be. And again, that's just not the case. And then secondly, I think that even in those that do realize that it's a dynamic injury and that change can be had, I think there's at times a lack of creativity in how to approach that rehabilitation and how that should take place. So at times I'm dealing with a lot of frustration with those referrals when they first get to me, and it's really a matter of, quite honestly, proving myself to them that we're going to go about this a different way, and it's going to be teamwork, and we're going to by God, we're going to figure out a way that's best for you.
Absolutely, and I think we probably have some of the similar instances. But when folks, reach out to me, it's often because they've seen 5 or 10 or more healthcare providers before they even show up to my door. And what I've been finding on my end, which I find consistent throughout our worlds of folks that are aware of what's going on with this injury, from a healthcare provider standpoint, is that patients are already coming to us with their own biases of the healthcare system. Again, we have all of these other third-party issues, like payer issues and things like that, which we won't get into, but our patients are essentially, with a brain injury, are battling to try and find the right healthcare provider. In terms of, your athletes that you're seeing on day one, are you guys doing serial assessments throughout? Are you tracking them throughout 7-10 days? Or what's your evaluation process look like?
Generally speaking, and I'm very fortunate here in the Louisville area because I work with and I'm surrounded by just absolutely world-class athletic trainers. I'm very, very fortunate. So at least how it looks like in my own practice is I prefer to see the athlete almost as soon as possible so that I can get on, the ground floor or get in on the ground floor and see how they look, as soon as possible at the point of initial injury. Mm-hmm. And then I will generally see the athlete at least once a week, if not more. If it's one of my collegiate athletes, sometimes I just simply have the ability to see them, even more frequent, a couple times a week. But in those days between my own evaluation, the athletic trainer is doing those more frequent serial examinations and serial evaluations, so that when things change, as they will, we're very much aware of where things are evolving in their specific case.
Awesome. Switching over to some of your history and education, I know that you are a graduate of the University of Oklahoma College of Medicine in Oklahoma City, and then you did your residency in neurology at University of Texas, Houston, and then you did your fellowship in headache and facial pain at the renowned Houston Headache Clinic. Now, that makes you very unique, and I'm very fond for my own referrals to, an interdisciplinary team. I really do like to seek out the fellowship-trained headache neurologist. And I know you guys are few and far between in the country. You guys are a very neat group of healthcare providers. And everyone has been so friendly and outgoing, and it's really just a great cohort of clinicians that you guys are a small cohort. Now, we know with concussion, post-concussion headache is associated with about 94% of concussions. So can you maybe go into your why you went into headache and then maybe how you kind of fell into the concussion world?
Sure. I initially went into neurology just because I found it fascinating, and I knew that I wanted a mix of both an inpatient outpatient practice, or at least I wanted that option, and just the fascination that I had with the brain, and then just how general neurology is set up from a practice standpoint. I knew that I would be able to go down both of those avenues if I decided to do that. So that went into neurology, and then within the realm of neurology, I quickly gravitated toward headache. I come from a family of migraine sufferers. Both my mom as well as my sister, both are migraine sufferers. My mom not so much anymore, but certainly as I was growing up. So I saw the impact that a primary headache disorder like migraine can have, on an individual, on a family, on work life, on social life. So that's where I chose to really take my neurology practice and my neurology interests. So I was fortunate when I was in Houston doing my residency to have one of the world's leaders in headache medicine, Ninan Matthew, there in Houston. And at the time, Ninan was the director of the Houston Headache Clinic. So I subsequently got plugged in with him to do a fellowship year in headache and facial pain. And it's just funny how life has twists and turns. If it weren't for Dr. Matthew, I probably, or I shouldn't say that, I wouldn't be where I am now. My fellowship year, Dr. Matthew introduced me to the world of concussion just simply because he took care of a number of the Houston area collegiate athletes and even professional level athletes that had ongoing headache issues from concussion. So we were seeing regularly athletes with post-traumatic headache and other issues, in relationship to their traumatic brain injury, as well as, the other primary headache disorders that we saw in the lay public. And it was during my fellowship year really that I knew that my two interests of sports and of neurology, and have a true sports neurology practice, which is, fortunately what I've been able to do in present day.
Absolutely. And, you speak about the functional disorders that derive from migraine, right? In both personal and all realms of life, right? Personal, social, familial, professional. And it just, you've already were almost set up perfectly to interact with patients with concussion and brain injury. Now we know that migraine is more common than asthma and diabetes combined in this country, in the United States. In terms of post-traumatic headache, what are you seeing with your patients that are acutely coming into your office, and then I would say the patients that maybe were missed and didn't think their concussion was quote unquote a big deal and kind of it was a wait and see approach? What are you seeing folks 6 and 12 months out in terms of post-traumatic headache and migraine post-concussion?
Right. Acutely, what really jumps out to me almost daily is that the majority of these acute post-traumatic headaches are very much migraine-like in presentation. They have the light and sound sensitivity, they have the activity intolerance, they have the underlying nausea and sometimes vomiting. So they look and act very much like migraine, and subsequently that's often how they're approached from a treatment standpoint. Now, on the other end of the spectrum, the more chronic post-traumatic headache, or the technical terminology in international classification of headache disorder criteria is persistent post-traumatic headache, i.e., those headaches that have lasted longer than 3 months from the time of inciting trauma. Often what I'll see in those chronic post-traumatic headaches is that they just simply weren't treated in the first place.
Right.
And it's very unfortunate, and I still see this on a weekly, if almost not daily basis, where someone will be referred to me 5 months out from their initial head trauma, and they still have unrelenting headache, and nothing's been attempted other than over-the-counter pain medication. When, for all practical purposes, if that headache had been treated, more assertively and more appropriately in the early time period, they may well not have been, still with having chronic daily headache 5 months post-injury.
Got it. In terms of medication, are you seeing a lot of rebound headaches coming through your door post-concussion, post-traumatic headache? What are you seeing consistently coming through you at
I
Norton
do.
Healthcare?
Yeah, I do, especially with those that are more chronic in nature, or those that are further out than 3 months from the time of the initial trauma. And there, in fact, there was an interesting study on this that was published just about 2 years ago that looked at chronic post-traumatic headache. And when the group that did this study actually began to interview the patients and began to apply ICHD criteria, they found that almost 3 out of 4 fit criteria for medication overuse headache. And subsequently, when the offending agent was withdrawn, that again almost 3 out of 4 had headache, almost complete resolution of their headache. So I do think in the setting of chronic post-traumatic headache that medication overuse headache does have a significant influence upon that.
And would you be comfortable explaining what medication overuse headache is and the criteria to fit into that?
Sure. Yeah. Medication overuse headache is essentially a secondary headache disorder that results from the overuse of any number of a particular different type of medication. It's most commonly seen with over-the-counter medications like Excedrin, like ibuprofen or naproxen, but it also can be seen with prescription medications like the triptans, like sumatriptan or naratriptan or rizatriptan. It can be seen commonly with opiate medications or narcotic-based medications. It's seen very, very frequently with the butalbital combinations, what we think of as fiorinol or Fioricet. Any or all of those, when taken with any of significant frequency, can cause medication overuse headache. Now, usually it's when someone is taking those more than 3 to 4 days per week, but you can see it with as little as 1 to 2 days per week of usage.
Absolutely. And in terms of, are you looking to medically manage your post-traumatic headache patients immediately right out the gate acutely, or do you have a wait and see with over-the-counter medications?
I would usually allow a conservative approach with over-the-counter medications initially. I certainly don't want anybody having to suffer through a severe debilitating headache, and if an over-the-counter medication early on is providing them some relief from that, then by all means, I'll certainly support them addressing it that way. And often in the case of acute post-traumatic headache, that's all that's ever needed, and the headache runs its course. The over-the-counter medications, it serves its purpose. It provides some relief over a brief time period initially until the headache resolves on its own. But it's when that headache doesn't resolve and when over-the-counter medications or other types of offending medications are used with significant frequency that then you can see the evolution into a medication overuse headache type scenario.
Awesome. And, that takes me into one of your recent articles that was published in the fall of 2017. And we're very lucky to have you as the head of the NCAA Headache Task Force. I know that's, new as of, 2014. Our NCAA Department of Defense headache consortium, our concussion consortium was put together. Now, this was published in the Headache Journal, and it's entitled The Comprehensive Headache Experience in Collegiate Student Athletes. And, it's an initial report from the NCAA Headache Task Force, which you obviously run. And some of the findings, were that a total of 23.7% of participants had a personal history of migraine. And this is, I think, important information for those that work in an athletic population to have in mind. Almost a quarter of folks in your study had a personal history of migraine. 25% had a history of sinus headache, and I definitely want to chat about that, the differential between sinus and migraine, especially for our emergency department providers that are often getting folks coming in that pathway. And then about 12.3% had a history of tension-type headache. And with that, you found a prior history of concussion in 46.3% of females reporting a history of migraine, and only 32.2% of males reported history of migraine. So I was just wondering if you could comment on that article.
Right. And to go back to the initial number that you'd quoted, the 23% or 23% reporting a personal history of migraine. That was somewhat eye-opening to us, simply because when you look at the numbers in the general lay public, the prevalence of migraine is closer to, depending on what paper you look at, 12 to 18%. So to have that be almost 1 in 4 was certainly higher than we had expected, and we still, to date, still don't really understand why. We have some theories, but we don't have a solid reason why yet. Some possibilities include, are we just simply capturing this population of individual at this age when we know that migraine prevalence does tend to be slightly higher than the general public? Is it because just simply migraines better understood and educational efforts are starting to take root and we're recognizing them better? Or is it something more ominous like the influence of contact sports? I don't know is the honest answer. But with phase 2 of the task force, with the prospective study, we hope to be able to delineate that and answer that a little bit better. The question about sinus headache was also interesting to us, with 1 in 4 reporting a personal history of sinus headache. And most people would not really look at that twice, but the reason that's important is because there was a seminal study published by Dave Dodick and Eric Eros back in about, gosh, I can't remember off the top of my head. I believe it was around 2006, 2007. They published a paper looking at a population of patients that were presenting to a tertiary care headache center with the complaint of, quote unquote, I have sinus headache. But again, when they applied ICHD criteria to those complaining of sinus headache, they found that over 80% actually fit criteria for migraine or probable migraine. So if you were to apply that same number of 80+% to our population in the NCAA paper, that would take the prevalence of those reporting a self-reported history of migraine north of 40%. So that's tremendously higher than what you would expect to find in that age group.
Yeah, that's tremendous. Those are tremendous numbers. And, for our emergency medicine providers, physician to NPPA and everyone in between in our emergency departments, we're seeing a ton of our folks that just don't know what to do, and they're not able to access, providers like yourself. Either it's an access or an educational standpoint, but they're going to the ED, right, the emergency department, for their migraine. To your ED providers, right? What are your recommendations for them for, differential diagnosis between a migraine and a sinus headache?
It really comes down to history. It's the difference between, or the ability to distinguish between sinus headache and migraine headache, in my opinion, is about 99% history. Sinus headache is more of a frontal headache. You tend to have exquisite tenderness over the frontal and maxillary sinus regions. You tend to have some nasal congestion, some nasal drainage. Sometimes even folks will run a low-grade fever. You don't tend to see really any of that in migraine. Migraine is more of a pulsating, pounding pain. At least in most people, it tends to be unilateral, or if not unilateral, it does tend to be worse on one side than the other. Again, in sinus headache, it tends to be bilateral. In sinus headache, it tends to be more of just a constant pressure-like pain. In migraine, you don't have nasal congestion, you don't have nasal drainage, you don't have low-grade fever. In migraine, you have nausea, you have vomiting, you have light and sound sensitivity. Those particular symptoms you rarely see in sinus headache. So it really comes down to just taking a good, solid, thorough history.
Indeed, and I think for everything we do in medicine, and that's tough. I think we need to advocate for ourselves, especially when third-party payers are trying to essentially make like 8-minute visits, and I'm like, we can't do that.
Yeah, absolutely.
We're
absolutely.
we're taking the care out of healthcare, and these are patients in front of us, and patients are people. So we always, I think we both have a personal history of my own personal concussion and recovery. Your mom and your sister, why you kind of went into the field, and kind of why I've trajectoried into concussion as well. So I think we have to make sure we're advocating for ourselves to basically spend time with patients, because that subjective history and that physical exam is so important on day one, and it really completely sets up our trajectory of care for our patient in front of us.
Absolutely. Yeah, my chairman, James Farindelli, who was my chairman when I was a neurology resident, that's one of the take-home points that I'll never forget. What he would always tell us as residents is 99% of the time the patient will tell you what's wrong with them if you just listen to them long enough. And I believe that. I've been in practice now since 2005, and I cannot think of an instance where if I just sat my butt down and listened, that the answer wasn't there. And I think that's just something that all of us need constant reminders to do.
Yeah, and I think that's a perfect place to kick off this, or to end this podcast here, Tad. And you've been such a wealth of information. What's the best way for folks to reach out to you? Is Twitter a good handle? I know you're really active on there. And
yeah, Twitter's great. My Twitter handle is at NeuroDocTad. That's Neuro Neuro Doc DOC Tad TAD. You can also email me at tad.seifert@nortonhealthcare.org. And my clinic's main number is 502-899-6782. Really, any of those are decent options.
Awesome, and I hope we set the listener up today for success to kind of tee them off for when they're looking at their headache and migraine, post-traumatic headache concussion patients. Thanks so much for coming on.
Thanks, Jessica.
Awesome. Thanks, Tad.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.